If you look at all the drug studies, the amount of improvement on the antidepressant drugs is probably around 70%, and the amount of improvement with placebo is probably 45 or 50%. So you got a window there of only 20%. But with this window and with a certain skill, you can still get people that are in terrible, terrible shape rehabilitated in fairly fast order. I'll start out with one course of antidepressants, and I usually will probably start out with the SSRIs. I'll probably give that for 3, 4, 5 weeks, and I bring it up to a high level fast, and I get discouraged if the patient doesn't get better in 3 or 4 weeks. So then I go on to antidepressant number 2. That'll be of a different biochemical nature. It's not going to be an SSRI. It could be a dopamine inhibitor. It could be a dual drug. And in this case, the patient is getting the benefit of a serotonin reuptake inhibitor and a norepinephrine reuptake inhibitor. So the spectrum that it should be able to treat is larger than the spectrum with just one mechanism of action. Then we finally have, if a patient is failing on all 3 of these, then I'll go on to an MAO inhibitor. And these drugs oftentimes will pull a patient out that none of the other 3 categories of drugs will. Beyond that, if you've still got a patient that's treatment resistant, we now have to say, well, is there anything left? If you've got a seriously depressed patient, doesn't want to get out of bed much, is suicidal, you've got transcranial stimulation. That's a thing they put in the back of your head. You sit in a chair and you get treatments for that, or you've got electric shock treatments, and that's the entire spectrum of treatment for depression.